the invitation to speak. You guys are developing a great resource here for sports medicine education, and I'm definitely an honor to be a part of it. I watched many of the prior lectures in the series, and I'll go ahead and just apologize in advance for bringing down the quality of the presentations. But I think without further ado, we'll roll forward. So just a little bit about where I'm from. I'm North Carolina here in Carolina Blue. Our best known athletic export is, of course, Michael Jordan. Pretty well heard of in the sports world, but I was thinking recently, perhaps more relevant to many of the people in the audience here tonight, our women's soccer program. I apologize for saying soccer. That's just going to happen. But is at quite a high level here. NCAA has held 45 women's soccer championships, and we've won more than half of them. And actually 4 Tar Heels: Lucy Bronze, Alicia Russo, Lotta Wubben-Moy, and then your manager, Serena Wiegmann, were on the 2025 Women's Euro champion Lionesses. So Tar Heel connections everywhere. Be careful, we're sneaky. I have no financial relationships to disclose. I do want to disclose that I am not a hematologist. Well, I've gotten into this work through a little bit of a roundabout path, but quite a lot of what I know and do in hematology, I have to give credit to my excellent colleague, Dr. Stefan Moll, who himself is a world-renowned hematologist. We run a clinic helping high-level athletes manage blood clots and anticoagulation issues for coming up on 10 years now, maybe 9 years now. And so most of what I say that's intelligent tonight comes from Dr. Moll, and most of what I say that's nonsense is of my own creation. And then Dr. Scott Berkowitz, actually a very successful hematologist in his own right, is actually my father. And so whatever you can learn about hematology genetically, I suppose I owe to him, but quite a lot I owe to him just in general. So hematology covers a lot of territory, right? In the States, to be a hematologist, you would go to university, and once you graduate, do 4 years of medical school, and then 3 years of internal medicine residency, and then 3 more years of hematology oncology fellowship. So maybe 10 years after college. I'm gonna have a hard time distilling that whole thing into 45 minutes tonight. So we'll narrow it down into sports hematology, but that, of course, is not that much smaller, and it's not even a well-defined field. I think mostly what we're referencing when we say sports hematology is, common hematologic issues that tend to present in the sports medicine world. So things like anemia, sickle cell trait, hemostasis. I'm going to keep infectious mononucleosis out of it. I think of that, I think understandably, as more of an infectious disease process. There are some hematologic manifestations, but those are not the main issues that we typically see with mono in sports. So for tonight, I'm really going to try, relevant to sports medicine, talk a little bit about anemia and hemolysis, a little bit about sickle cell trait and related collapse, some about bleeding and hypercoagulable disorders, venous thromboembolism, and then venture into some of the more novel stuff that I suspect is what got me on anyone's radar to invite me to do a talk like this. And I'll try to be at least moderately entertaining. I understand, for me, it's 2 p.m. We're just in the middle of my workday, but I know I'm encroaching on your evenings, and so I'm going to try to make this worth your while. And so we'll just jump right in. We'll start with anemia. Simple definition, right? This is a reduced volume of red blood cells or of hemoglobin concentration in the circulation. Red blood cells deliver oxygen to tissues. Hemoglobin binds that oxygen to facilitate the delivery. So if you're lacking in those, you struggle with oxygen delivery. It tends to give fairly general symptoms: fatigue, weakness, headache, maybe some lightheadedness or dizziness. As it pertains to athletics, that's not great. You do want to be able to deliver oxygen to exercising tissues. So athletic performance, exercise tolerance tends to go down. If things get more severe, you can start to get into more cardiopulmonary issues. How do you become anemic? What causes it? I tend to think of it in these groups, right? You can either, if we're just talking about red blood cells, you can either not make enough. You can have enough, but you can dilute them out in some way. So that the concentration's not high enough. you can sequester them, right? If you have enough red blood cells, but a lot of them are sort of hidden away somewhere, such that they can't be used, then you may have enough overall, but you don't have enough accessible. And then you can lose them. They can get destroyed, or you can bleed. You can lose blood that way. Relevant to sports medicine, then, the most common factor associated with underproduction is iron deficiency. There are other nutritional deficiencies that can play roles. We'll talk a little more about that. In terms of dilution, it's actually relevant because there's this entity, it goes by a couple of different names. I'm going to say athletic pseudoanemia, but that just relates to the fact that, when individuals train for sport, particularly endurance sport, eventually over time, you do tend to generate a higher overall red blood cell volume. But blood is not just red blood cells; it also has serum, or the other fluid, in the blood, and that serum volume actually can increase more quickly than the red blood cell volume does. So you may have an appropriate number of red blood cells. When the serum volume increases, that relative concentration of red blood cells goes down. And if you were to check someone's labs at that time, it may look like they have a mild anemia, but it's called a pseudoanemia for a reason, right? It's not actually an anemia. It's just sort of a transient phase in training that can be identified. Sequestration doesn't play a huge role in the anemia relevant to sport medicine, again, particularly or potentially in the setting of something like infectious mononucleosis, where the spleen can swell and maybe sequester some red blood cells. That's not super relevant for tonight. And then loss or destruction, these things can certainly happen. You can have a traumatic hemorrhage, right? If you get cut and you bleed out, you lose blood, or even internal bleeding, some type of visceral injury, splenic rupture, or something like that. Or atraumatic, not specific to sport, but menstrual bleeding, GI bleeding from too much, non-steroidal anti-inflammatory use, or something along those lines. And there's also this entity of exercise-induced hemolysis that destroys red cells, and we'll touch on that more. So iron deficiency is the most common nutritional deficiency worldwide. Again, I'm stepping away from sports for a second. It's just a common thing. Female sex, adolescence, endurance sport training, actually multiple pregnancies, lots of things are risk factors. Iron deficiency alone, so a low ferritin level in the blood is something that might be identified, does not always cause anemia. Your body can compensate for low iron, to some extent and for a while. So not everyone with iron deficiency has anemia. Sorry, awkward time for a phone call. But if iron deficiency is severe enough or lasts long enough, then that can actually cause an anemia, right? If you don't have enough iron to make all the blood cells that you need to make, then you can become anemic. And again, that iron deficiency typically results from either inadequate intake of iron or blood loss, where you lose a lot of iron in blood loss and don't have adequate stores to replete, or I suppose both. And in this case, you would find low ferritin in the blood, i.e. low iron levels overall, but also that hemoglobin concentration will drop, sort of making you anemic. And this measure called an MCV, mean corpuscular volume, which is essentially an estimate of the average size of a red blood cell. Iron deficient folks tend to make smaller red blood cells, so a low mean corpuscular volume. Treatment-wise, right, this is not the rocket science portion of the show. If you have low iron, the treatment is to give iron. So that can be through nutritional sources alone. Usually it'll be through some sort of oral supplement, iron supplement, and in severe cases can be intravenous infusion. But always important is to address the underlying etiologies, right? So if you've become iron deficient because you eat a diet extremely low in iron, you might want to adjust that. Or if it's from blood loss, right, extremely heavy or prolonged menstrual bleeding on a monthly basis, then addressing that will actually give you a much better chance of catching up on the iron deficiency and thus the anemia. I mentioned I'd talk a little bit about hemolysis, particularly exercise-induced hemolysis. The cause of it's not extremely well understood. It was first noticed in soldiers and in distance runners. In soldiers, on long ruck marches where they're going miles and miles and miles and miles, day after day after day, with that foot kind of striking the ground on a very regular basis. And so it initially got called March hematuria for that reason. But it's subsequently been documented in other endurance athletes, including swimmers. So it doesn't necessarily have to be, an impact activity. It does seem to correlate with higher duration or longer duration and higher levels of intensity with exercise. And it often improves with reduction of impact. So I think there is a role of impact, but also potentially a role in some individuals of just sort of muscle contraction causing some shearing and hemolysis and some metabolic factors specific to individuals. It's a diagnosis of exclusion, meaning if you have an athlete who seems to be hemolyzing, right, seems to be rupturing their red blood cells, sort of internally, spontaneously, don't just assume it's this, because many causes of hemolysis are actually quite concerning. And so it requires a medical workup to ensure that the hemolysis is not coming from a more medically concerning reason. And you would only call it this if kind of everything else checks out, and it really does just seem to be related to some sort of mechanical trauma. Folks with exercise-induced hemolysis may have anemia and the associated symptoms that we discussed, or sometimes urine discoloration is what shows up. If you have anemia from this, it's usually pretty mild, often macrocytic. So I mentioned iron-deficient blood cells tend to be a little smaller. In the setting of hemolysis, when you measure blood counts, oftentimes the average red blood cell is actually a little bigger than average. So what's called a macrocytic anemia. The urine discoloration in exercise-induced hemolysis actually comes from hemoglobinuria, right? So hemoglobin in those red blood cells is, the red blood cells rupture, the hemoglobin is in the bloodstream, the kidneys filter that out, but there's a lot of it. So you'll kind of see the pigment change in the urine. Myoglobinuria, of course, you might see in exertional rhabdomyolysis, where muscle cells are dying and myoglobin is going into the bloodstream. Visually, it can look similar, but from a laboratory testing standpoint, we can distinguish that. To further complicate things, there is this entity called exercise-induced hematuria, where people just simply have blood in their urine as a result of exercise, not from hemolysis, not from isolated hemoglobin or myoglobin. So a bit complicated, but basically urine discoloration can trigger a workup. In general, stop making it worse, right? So generally speaking, just backing down on activity, relative rest, modifying activity, or again, something as simple as maybe like, a better cushioned shoe can be enough to kind of help this get turned around. On to sickle cell trait. So again, just a little bit of the basics of this disease. So the predominant form of hemoglobin in most adults on this planet is called hemoglobin A. So if you get a copy of a gene for hemoglobin A from one parent and hemoglobin A from the other parent, you're hemoglobin AA, and that is generally considered normal hemoglobin. Some individuals have a mutation in the hemoglobin gene associated with those blood cells kind of turning into a sickle shape, and that gene is called hemoglobin S. So if you get one gene for hemoglobin A from one parent, right, a quote-unquote normal hemoglobin gene from one parent, but a hemoglobin S gene from another parent, then that genotype is hemoglobin AS, and this is sickle cell trait. It affects about 300 million people worldwide, so it's pretty common. To go one step further, if you actually get a hemoglobin S gene from both parents, right? Because again, lots of people have at least one hemoglobin S gene that they can pass along. So if both parents pass along their hemoglobin S gene to a child, then that individual will have hemoglobin SS genotype. This is sickle cell anemia or sickle cell disease. Fortunately, less common, but still affects about 8 million people worldwide, and this is a really bad disease. So sickle cell trait is very different from sickle cell disease in terms of the phenotype and how people do quality of life and health-wise. Sickle cell trait. So why are we even talking about this? Well, these sickled red blood cells that are more common if you have that hemoglobin S gene can ultimately obstruct small blood vessels, leading to ischemia, infarctions, right? Basically like tissue death beyond those obstructions. That's not good. And again, sickle cell disease, which is hemoglobin SS, is very serious, and it's serious enough that you will not encounter high-level athletes who have this. You're just not going to be physically well enough, with I guess perhaps rare exceptions, because humans can do special things sometimes. But it's just not really a factor in the sports medicine world, because you just kind of can't be well enough to compete in high-level athletics, at least with sickle cell disease. But sickle cell trait, having one hemoglobin A gene and one hemoglobin S gene is actually mostly asymptomatic. Most people, if you never tested them for it, would live a totally normal life and never know they had it. But there are some exceptions. And the big exception that we talk about, with regards to sports medicine is ECAST, exercise collapse associated with sickle cell trait. It was initially controversial, but the data is pretty clear now. Sickle cell trait is associated with exercise-related death, particularly seen in like military and athletic environments where large groups of individuals with some frequency, sort of go from a relatively low fitness state and then get thrown into some sort of boot camp or training camp or some sort of, very rapid escalation into aggressive physical activity where, quitting and taking breaks is strongly discouraged, right? And so people are really kind of being pushed to and maybe past limits. You're at higher risk, again, if you're starting at a lower level of physical fitness, or some environmental factors, altitude, heat, dehydration can play a role as well. People who collapse with exercise, there's a fairly broad differential diagnosis that can be associated with that. What sets ECAST apart? So again, this is typically associated with intense exertion. It could be early in a workout or late. But generally speaking, people are most commonly described as sort of, more slowly slumping to the ground. You can contrast that with a sudden cardiac arrest, in which case that individual, suddenly becomes dead. They drop hard, right? Like there's no like letting yourself down gently. Like when your heart stops and you go down, it's not subtle. So these individuals with ECAST are generally conscious at first. Obviously a little ominous that I say at first. Also, weakness is more prominent than pain. Again, another thing that someone who's exercising hard might, collapse for is something like exertional muscle cramping, where the muscles become rigid, they're very painful. The individuals may have leg or back pain in particular, but in general, it's more an issue of weakness and things just not functioning well, more so than being really pain predominant or really rigid muscles. And then the real concern is you can see relatively rapid progressive decline of mental status and cardiopulmonary status, sometimes progressing even to cardiac arrest, often as pulseless electrical activity, PEA. For anyone who's done, basic life support, kind of CPR work, PEA is a non-shockable rhythm, right? So those AEDs that we have all over the place that are really important in saving lives cannot shock people out of pulseless electrical activity. So that's a bad outcome for most people. Not that any cardiac arrest is good, but some are more treatable than others. So with ECAST, it's really important to recognize this early, right? If you have an individual who has sickle cell trait, who is struggling through their exercise, rather than continuing to push through until they collapse, pulling them from activity sooner rather than later is very helpful. If you have concern for ECAST, again, you're going to activate your emergency response. In the States, it's 911. I think in the UK, it's 999 and maybe 112 in Europe. I don't know why I'm telling you this. You guys know this. Maybe I just made a fool of myself. Activating the emergency response and getting the AED. There is no harm in having an AED next to you while you do an evaluation. And if the patient doesn't need it, wonderful. But having it around if you need it is a good move. And with this particular entity, having it around is a good move. You'll, of course, perform your assessment. If no pulse, not breathing, you go straight into CPR. Assuming they are still conscious, they have a pulse, they're breathing, then high flow oxygen. At some point, probably worth measuring a temperature, ideally a rectal temperature, because there can be some overlap in presentation with, like exertional heat illness, heat stroke. So of course, cool them if indicated. But then I would have a low threshold to transfer these individuals pretty quickly to a higher level of care, because if this collapse happens on the sidelines or somewhere where you don't have a lot of resources, this individual has a lot of potential to progressively get worse. And it would be much better if they're going to get worse to be worse somewhere where there's a lot of support, as opposed to a more isolated or less resource-rich area. Recognition is really important. And so there's some controversy about screening everyone for sickle cell trait. But it's really hard to diagnose ECAST if you don't know if someone has sickle cell trait, right? This is by definition something that only occurs in sickle cell trait. So for me, you know, the NCAA, the National Collegiate Athletic Association here that our university is affiliated with, mandates sickle cell testing, which is helpful for us because we know who has sickle cell trait and who doesn't. But some people just argue for universal precautions, right? Treat everyone as though they might. So, you know, make sure that you're not taking people from a low level of fitness really aggressively into, you know, intense activities at the beginning of a season or training period, you know, heat acclimatization, making sure the hydration's available. And then the education and cultural component, right? You know, if I am on the sidelines at an, you know, I was at our football practice, American football practice this morning, we have 105 players, you know, on the field. I mean, we have a staff, but it's hard to keep eyes on 105 players. But if the other players are educated, if the coaches are educated, if other people can identify when someone is doing poorly and they know to encourage them to remove themselves from activity, that can be really helpful. And that's what I mean by that cultural commitment too, right? If you have a coaching staff that, you know, when someone is running sprints and starts to wobble, they scream at them to toughen up and tell them don't get water, you know, because that's for weak people. That's really a problem. Versus if you have a coaching staff that might recognize and be informed that this is potentially an issue, and that individual should be assessed by the medical staff, and then of course can come back into activity if they're cleared to do so. But you need that cultural commitment, or else people don't tell you when they're doing poorly. All right, shifting gears a little bit to bleeding disorders. We'll talk about a few different things. Um, So hemophilia is something that I think everybody's heard of and may know something about. There are three main subtypes. The most common one, hemophilia A, is a deficiency in clotting factor 8. But there's also a deficiency in clotting factor 9, hemophilia B, and a much less common one in clotting factor 11, called hemophilia C. The severity of hemophilia is just classified by how much of your factor activity you have. So people actually clot awfully well if they keep, you know, even half of their factor function. You start getting much below 50%, and people have more problems. And the more severe case of hemophilia have like less than 1% function, right? So one of these clotting factors basically, you know, barely works at all. Um, you do not have to memorize this. I put this up to make it seem like I'm smart and I have this thing memorized. But it's also mostly just to highlight, you know, a specific place in the pathway, you know, where for hemophilia A, factor 8 works here, factor 9 is here, factor 11 is here. So all of these kind of hemophilias are in the same sort of region of the pathway, and that's why ultimately, from a phenotypic standpoint, they can wind up with sort of similar outcomes. But no need to memorize this. Not that you were going to anyway. So in hemophilia, people have, of course, elevated risk of bleeding just at baseline, right? They can bleed spontaneously. Sometimes it's an elevated risk. Certainly trauma is not great for these individuals. When hemophiliacs bleed, it's often intra-articularly, so what's called hemarthrosis, right? Bleeding into joints. Obviously, maybe not obviously, it is painful and it causes a lot of disability, but also long-term issues, a bunch of bleeding into joint over time. Some people with hemophilia, you develop really bad arthritis at really young ages, you know, 20s, 30s, with, you know, completely shot joints. Not uncommon to get intramuscular bleeding, so hematomas. Fortunately, intracranial bleeding is not super common, but it's obviously the most dangerous if that were to happen. And then bleeding in other sites can happen too. Routine care for hemophilia, right? It's important to keep in mind, I mean, really with every medical condition, specific here to hemophilia, people with hemophilia are people with hemophilia. So, like, you know, they do need to live healthy lifestyles, eat well, get exercise, right? So you don't wrap them in bubble wrap and tell them not to get off the couch. They need to do things. Of course, you're going to try to stay away from medications that can increase bleeding risk. You know, non-steroidal anti-inflammatories can interfere with platelet function. The COX-2 selective ones, like celecoxib, is the big one that's on the market in the U.S. You may have others depending on where you practice. Those really don't interfere with platelet aggregation much, but in general, we just stay away from NSAIDs. These individuals don't need any more help bleeding. They bleed fine on their own. Don't do anything that can make it worse. And And then there is factor, like medication that can be used to replete factor. Some folks are on continuous factor administration. I'm meaning it's scheduled. They just like use factor on a regular basis to keep their levels high. Those are usually people who've had a lot of prior bleeding problems. Or just a severe disease, right? The less than 1% function where they're likely to have a lot of problems. Folks with less severe hemophilia sometimes just, take factor prior to a dental procedure, like where there's going to be some trauma, there's going to be some bleeding, and so they try to mitigate that. Or again, if they were to participate in some risky event, they might, just prophylax with an intermittent dose, but they don't do it all the time. So as far as athletic participation with hemophilia, I mean, this needs to be an individualized decision, right? And I think a lot of medical care probably should be that way. If you're participating in sports, obviously you're going to be monitoring closely for signs and symptoms of bleeding, and depending on the sport, depending on the specific circumstances, probably some degree of prophylaxis, right? Take some factor ahead of time to get your factor levels up to good clotting levels in the event of trauma. But there have been a lot of studies that show sports participation can absolutely be safe for people with hemophilia. Um, you know, Probably staying away from the collision sports, right? I don't know that rugby is necessarily the ideal choice, but you don't have to be totally inactive or unathletic just because you have this condition. If people with hemophilia bleed, then giving them factor is the treatment. The other measures that can help, compression and things like that you would do for a major bleed, you certainly can do here as well. And then having a low threshold to transport these individuals to a higher level of care. Again, if you're not prepared to transfuse blood if they keep bleeding, then they should probably be somewhere that is prepared to transfuse blood if they keep bleeding. Along the same lines as von Willebrand disease, this is actually very common and probably significantly underdiagnosed. Von Willebrand's factor actually works to stabilize factor VIII, which is the factor that is deficient in hemophilia. So when you don't have enough von Willebrand factor, then your factor VIII doesn't last as long, doesn't work as well, and so you get symptoms kind of similar to not having enough factor VIII, like hemophilia. There are a couple of different subtypes, and they vary whether it's you don't have enough von Willebrand factor or you have plenty but it doesn't work well. These are mostly autosomal dominant in inheritance, so they're passed along a little more easily than hemophilia is. Folks with von Willebrand disease tend to bruise easily. If they get nosebleeds, they may linger for a while. Menstrual bleeding may be more pronounced. They may have small medical procedures, dental work, and they bleed more than they're kind of quote unquote supposed to. And so, if you have suspicion, you can certainly work that up, right? If someone just seems to bleed too much, bruise too easily, or has like some family history, or even just a low platelet count, sometimes is associated with von Willebrand disease, not always. These folks have slightly elevated bleeding risk at baseline. Again, it's not typically as bad as like a hemophilia A, but of course, trauma increases risk. While with hemophilia, you see more bleeding into joints and muscles. It's more mucocutaneous, including menstrual bleeding, gums, things like that. And again, just the severity or persistence of bleed, like you just kind of bleed a little more, a little longer. It's harder to stop the bleeding than you might think. Fortunately, not a lot of GI bleeding, not a lot of musculoskeletal bleeding, not a lot of intracranial bleeding. Same kind of deal. These folks are normal people who need to be active and can participate in normal activities, still staying away from NSAIDs. There are a couple of medications, depending on the type of von Willebrand disease, that can be used. That's probably beyond the scope of interest for most of the audience here tonight. So again, usually considered safe to participate in sports. The most severe form of von Willebrand disease may require some additional thought, because that can actually be pretty risky from a bleeding standpoint. You're going to monitor for signs and symptoms of bleeding. All the basic stuff will hold over. And then if people are bleeding, depending on the severity of their disease and kind of what medications work for them, you've got a couple of options. ITP, immune thrombocytopenia, can come about through multiple mechanisms, whether sort of out of the blue for no reason or related to something else, another medical issue, or drug-induced, like pharmaceuticals. typical presentation, petechiae, little like pinpoint bruises, or purpura, kind of bigger bruised areas. Again, nose bleeding. Sometimes it presents with intracranial bleeding. That's obviously catastrophic. You don't even know there's a problem, and then you bleed, but thankfully that's rare. Platelets will always be under 100,000. Most labs use a lower limit of normal is 150,000 platelets per microliter of blood. So, less than 100,000 is already well into the below normal range. The severity of immune thrombocytopenia is more classified by whether you bleed or not. So it doesn't correlate as closely with how low your platelet numbers are. Some people have really low numbers but don't bleed, and that's great. Some people have relatively higher numbers but bleed, and that's a problem. Again, more of a mucocutaneous bleeding issue, not so much musculoskeletal, intracranial, or in the gastrointestinal system. And again, we're going to stay away from NSAIDs. Generally speaking, your platelets can get down pretty low, and the risk of spontaneous bleeding is still quite low. So, a platelet count of 20,000 is actually very, very low. But you tend not to have bleeding, like even approaching those levels. You get below 20,000, that's probably when you're at more risk of spontaneous, including intracranial bleeding. There's very little, maybe no, good data about athletic participation in ITP. A platelet count of 50,000 and above, again, still well within the sort of low platelet range, but 50,000 or above really is just not associated with much bleeding. And so most athletic participation will be felt to be safe at this level. But again, you got to decide based on the individual, what's the sport, why does it matter so much? And correlate with bleeding history. If they have pretty good platelet numbers, but they bleed all the time, they're more likely to bleed again. If you have ITP and you bleed, then platelet transfusion is really the way to go. Steroids and IVIG can be helpful adjuncts to treatment. So from bleeding too much to clotting too much, these are probably the major relevant hypercoagulable disorders, things that really predispose to clotting excessively. And again, just to kind of touch on where these things work, protein C breaks down the activated forms of factor V and factor VIII. And so, if you don't have enough protein C, right, protein C deficiency, then you often can't adequately degrade those activated clotting factors, and so the clotting factors are more active and you clot more. Protein S helps protein C work, so if you don't have enough protein S, it's like having not enough protein C, and kind of on and on down the list. Factor V Leiden gene mutation encodes a resistance to protein C, so you have enough protein C, but it doesn't work that well. So again, you still have sort of unchecked clotting factors. Like antithrombin, of course, inhibits thrombin. Thrombin is important for clotting, and so if you have a deficiency of something that is important to inhibit clotting, you get that double negative effect, and it tends to be pro-clotting, pro-coagulant. Prothrombin gene mutation, again, works the way that it sounds like it works. Antiphospholipid syndrome is complicated, but just take my word for it, it tends to make you clot. So we're back to that coagulation cascade, and really the places that we're working here, antithrombin works at this level, protein C, protein S, prothrombin work around there. So for hypercoagulable disorders, we don't recommend just screening everybody, but you would think about it if someone has a strong family history of blood clots, or if it's known, oh yeah, my grandfather had protein C deficiency, well, then your parent might have it, and they may have passed it on to you, even if you haven't clotted. Antiphospholipid antibody syndrome is not hereditary, but the other 5 are. Okay, so venous thromboembolism. I'm going to pivot over to sort of a modified version of a talk that I gave at our advanced team physician course, maybe in 2023. And so I'm going to start with some basic stuff, and then we'll get into the off-book stuff that we have been working on here for a little while. So VTE, it's a term that encompasses both DVT and PE. It's common in the general population. It occurs in athletes. For lower extremity blood clot, often pain, swelling, and warmth. Upper extremity blood clots are less common, although some throwing athletes can certainly get it. Other people can as well. Pulmonary embolism is more shortness of breath, chest pain, coughing, and athletes can compensate well. So they may have a PE and just have a persistent cough and otherwise kind of seem mostly okay. So you got to keep an eye on them for sure. Clots in the legs are generally diagnosed by ultrasound. Clots in the chest, like PE, are generally diagnosed by CT. When you have a clot, you start anticoagulation, blood thinners, straight away. Used to always be with some IV or injectable version like heparin, low molecular weight heparin, but these newer direct oral anticoagulants are more commonly being used. And you continue treatment for 3 to 6 months. Again, historically with warfarin, these days more with these DOACs, direct oral anticoagulants. And then if you need secondary prevention, then you might be recommended to take blood thinning medications indefinitely. There are 4 direct oral anticoagulants that are on the market in the US, maybe a little bit different again, depending on where everybody else practices. Apixaban and rivaroxaban are the only ones that are indicated for initial monotherapy for VTE, meaning you can use the other ones for treatment, but with apixaban or rivaroxaban, you don't need to bridge with treating with heparin like while they build up into your system or anything. Basically, the moment you take a dose, you are considered protected, similarly to if you had been given intravenous heparin. In terms of risk for VTE, many are provoked, can be provoked by trauma, surgery, immobilization, etc. Oral contraceptive use is one that we'll see in a lot of our student athletes. But they can be unprovoked. Unprovoked, as I'm gathering most of you speak the English language, just means not provoked, right? So we don't have a real reason for it. It doesn't fall into one of the categories above. Provoked, uncomplicated VTE is treated relatively straightforwardly. You start your initial anticoagulation, these days often with apixaban or rivaroxaban, one of those direct oral anticoagulants. You resolve or sort of get past the time window of the provoking risk factors. Like if you had surgery, once you're past the surgical window and no longer in a cast or whatever, then your risk is gone. You complete your 3 months of primary treatment, and then you're done. That's great. If you have an unprovoked VTE or VTE with an unresolvable risk factor, right? So say you clotted and we tested and we found out you have protein C deficiency. Well, you can't change that, right? So now that risk factor actually can't go away. So you need the initial anticoagulation, you need the 3 to 6 months of primary treatment, but since your risk factor is not going to go away, the likelihood of you having another clot is actually fairly high. And these events can be fatal, right? They can certainly be harmful, and they can definitely be fatal in some circumstances. So it may be worth staying on a blood thinner for a long time, which for some people is fine, and for other people can be a huge problem, particularly some athletes. So what do we think about? My role as a primary team physician is to protect the health and safety of the individuals under my care, just like any physician. The second sentence is extraordinarily convoluted, and I'm proud of it. But it's sort of a tongue-in-cheek way of me saying I treat every patient, or at least I try to treat every patient as an individual. And so, for some individuals, you have to consider the cost of medical care. That's a big issue in the United States. For some issues, you have to consider, you have to consider whether a patient has transportation to go to where you want them to get the treatment. Because if they don't, you need to come up with a different treatment plan. And for some people, their livelihood is their physical health and athletic performance, and taking that away from someone is really a bigger deal than for me being on an anticoagulant sitting here giving this lecture is not a big deal. Once someone is diagnosed with a VTE, you don't interrupt their anticoagulation for the first 3 months. That's always a bummer, but 3 months out from sport is manageable for most athletes. And you don't have to be bedbound that whole time. Really, after about 3 weeks, any clot that may remain in a vein very likely is very strongly adherent to the vein, sort of scarred in, so to speak, and it's not going to go anywhere with activity, weightlifting, running, particularly since you're still on the blood thinner that helps to prevent that. Obviously, you need to clear any cardiopulmonary issues, right? If you had a big heart or lung problem from a PE, you need to get over that before you're going to be able to return to exercise. But the clot itself is usually stabilized or dissolved within 3 weeks, and getting back to activity, building up during that 3-month time period is totally appropriate and actually recommended. So athletes can get back to sport once their anticoagulation is complete after 3 months. But if you're recommended to be on extended anticoagulation that doesn't end at 3 months or 6 months, again, the old thinking was then you're just done with sport, right? It's just not safe. You can't do that. We have to protect your safety. This is a bummer, but you're done. And what Dr. Moll and I think have kind of gotten on the map for in this realm in the past 10 years, due to some publications and presentations and such, is just things have changed a little bit from when we came up with that original consensus. And we think it can be reconsidered. And you still need to keep risk low, but I don't know that we necessarily have to disqualify everybody. Why do I say this? Well, historically, we just had warfarin. That was the main oral anticoagulant available to people. There were some injectable ones, but people do not want to take injections for months, let alone for life, if they can avoid it. So we use a lot of warfarin. It takes a long time to become therapeutic. It takes a long time to get out of your system. You can't turn it on and off very quickly. It's difficult to deal with even under the best of circumstances. So with that as our main tool, we didn't have a lot of flexibility. We have more flexibility now. These DOACs are very well established. They work very well. They're largely replacing warfarin on the market for most indications, which is appropriate. They're frankly better medications. And one thing that's better about them is you can turn them on and you can turn them off much more quickly. So that is the key feature, I think, that gives us more options than we used to have. So taking a little bit of a step back, for any medication, in this case an anticoagulant, when you take a dose of medication, it absorbs into your bloodstream, it hits a peak, and then your body starts to clear it out, and eventually it's gone, right? On the right is a diagram from a study done, published in 2013 at least, of blood levels of rivaroxaban across a broad range of people who took a single 10 milligram dose. So for most people, it kind of hit their peak around the 2-hour mark, and then it started clearing from your body. And some people had it cleared, completely to zero by about 24 hours, right? That was like the 5th percentile in terms of speed, right? These people did it real fast. On average, it was maybe at a level below 10 at 24 hours. And some people still had a level, close to 40, 35, 40 at that time. So there's a lot of intra-individual variability in this. But for any of these people, somewhere along the line, as that medicine is clearing your system, it'll get to a low enough level that the amount of drug in your system, is maybe increases your risk for bleeding a little bit, but perhaps at an acceptable level, right? It increases your risk. And I'm just making up these numbers, but from 1 in a million to 1.4 in a million, well, that's not that big a deal, right? That is a higher risk, but potentially acceptable. And eventually it gets down to a negligible level, right? At some point it's gone, or at such a low level that the medicine just has no effect. And so at those time points, you could think about whether, athletic participation could be done, right? Negligible, you would certainly say athletic participation will be okay. The question is, where is acceptable? Based on what is essentially at this point expert opinion, this is not strongly evidence-based, although we have some backing for this I can get into later. I'm using a threshold of less than 10 micrograms per liter. We feel very safe with in terms of calling that an acceptable level of risk. So if you're below that level, your increased risk of bleeding with athletic activity is probably very, very slightly increased from baseline, or perhaps not at all. So for some individuals who are fortunate, right, for example here, maybe a baseball shortstop who practices at 3 p.m. every day, if he happens to be on this fortunate navy blue line and he clears, below this threshold of 10 milligrams, by 18 hours, maybe by 15 hours, then he can be on anticoagulation, taking his dose at 7 p.m. every night. It is largely cleared from his system to an undetectable level by 1 p.m. the next day. So he can practice from 3 to 5 every day. If he gets hit with the ball, he's really at very minimal risk of bleeding. assuming he doesn't get, too badly beat up, he can take his dose of anticoagulant later that night. And so he'll take his daily dose every single day and yet still can potentially play his sport safely while fully anticoagulated. Some people aren't as lucky. It takes a little longer to clear. So maybe if you're more in the mean, it takes you a full 24 hours. Say we have an American football quarterback who practices at 8 a.m. every day. You know, one thing about American football, no one is allowed to hurt the quarterback, right? Most important position on the field in terms of winning, at least. And so coaches do not let their teams hit the quarterback during the week. They wear a different color jersey so no one will make a mistake. No one will hit the quarterback. Except, in college football, in the States, games are usually played on Saturday. So on Saturday, the other team will try to kill the quarterback. So, for instance, this individual could even take his dose at 7 in the morning. He can be at peak level during practice. Doesn't matter. He's not going to bleed just throwing a football around, and no one's going to hit him. He'll get no contact during the week. On game day, which we typically play, 12 to 14 games per year. So on game day, we would hold his dose, right? His 7 a.m. dose would be out of his system by 7 a.m. Saturday morning. Don't dose him on Saturday, so he has no detectable blood thinner in his system for game time later on Saturday, and then potentially restart medication on Sunday. So yeah, he'll miss a couple doses a year, say 13 games. That's still 96% adherence. He's probably pretty well protected against recurrent clot. And some people are not so lucky. Some people are on this gray line. It takes them forever to clear their medicine. Say you have a gymnast, really anytime a gymnast practices, they're at risk of trauma. You could hold their medication on days they practice, but they practice pretty much every day. So then they're not taking their medication. In some situations, this just simply won't work. So we are by no means advocating that everyone on anticoagulation should participate in sport, particularly contact or collision sport. But just I'm suggesting that there may be some circumstances where it could be considered. So, we come to this from a point of view of patient-centered care, right? In some cases of VTE, you need extended anticoagulation. In some cases, you can compete in sport on continuous anticoagulation. The parameters need to be appropriate. In some cases, maybe some minimal interruption is appropriate. You sort of balance, the risk protecting against clot versus the risk of continuing their sport and having some bleeding. And in some cases, it doesn't work, right? Again, we don't want to be crazy about this. In fact, we want to be quite thoughtful. But in all cases, what the patient wants matters. So, for this idea that we've called individualized intermittent anticoagulation, essentially, you treat VTE with 3 months of uninterrupted anticoagulation. If they need longer treatment, then that can certainly pose an issue. Patient preference matters, but you don't necessarily have to disqualify them out of hand. The DOACs give us tools we didn't used to have. It's labor intensive. It requires an individual pharmacokinetic study and maybe multiple, shared decision-making, risk management, a support team. You got to be lucky. You got to clear the medicine quickly enough. Lots of things need to go into it, but it's something that we think can be done safely. And in fact, we're in the process of drafting a manuscript. We have about over 50, maybe close to 60 high-level athletes who will involve in the manuscript. Again, thanks to Dr. Mole. He's really the brains of this operation. So here we are. So hopefully we met our objectives. I think we did. Okay, well, that was a little harsh, but I think we're trying to save a little time at the end, so I'll move on to questions, and I'll pass it back to Andrew or Ollie.
Thanks, Josh. That was a really fantastic presentation, and I'm definitely going to have to watch it back at least once or twice more because I couldn't take notes fast enough. Pharmacology knowledge way beyond my capability, but there we go. If everybody could post questions in the Q&A, that would be great. We will work through them broadly in some kind of order. I am going to be a little bit selfish and kick off with my own question, just to give people some time to pop theirs in. And I just wanted to go back to the sickle cell that we were talking about earlier. I'm conscious that a lot of the clinicians on the session and people who'll watch this afterwards will probably be working in environments or settings where they don't have the facilities to routinely test people for this. And so we'll largely be working in the dark. What's the prevalence, first of all, broadly in athletic populations, but also what symptoms should people be looking out for that would give us a level of suspicion that this might be going on, and I need to get this person, you know, bloods done in to see a hematologist, etc.
Sure. So yes, I mean, so what's interesting about sickle cell trait is, for as bad as having 2 copies of hemoglobin S is, having 1 copy is again, is, I mean, largely thought of as an asymptomatic carrier state, right? So you may have many individuals who have participated at very high level athletics, in heat, at altitude, all sorts of things, and never had a problem. So fortunately, it's uncommon to have these problems. The incidence of sickle cell trait is quite high. A lot of people have this, largely individuals with heritage from Africa and to some extent Mediterranean. There are other hemoglobin variants that are more Asian subcontinent and other parts of the globe. There's actually an interesting backstory for the sort of theory about why this hemoglobin S variant is so prevalent in the population. It may actually confer a little bit of protection against malaria. So places that historically have been very prevalent with malaria tend to actually see this gene more commonly. But I think that gets back to, if you don't have the ability to test or screen for sickle cell trait, then those universal precautions, right? Don't do the crazy boot camp thing where you bring in 60 out of shape people from the summer and try to kick their butt and make them run until they vomit on day 1, right? Like, you can just simply be more rational, be more gradual. And honestly, anyone who looks like they're struggling with the activity, you should probably allow them an opportunity to have water pull themselves out. If you have someone who has sort of more minor episodes that have you potentially concerning for an ECAST event, right? They have these episodes of sort of getting a little bit weak, a little bit wobbly, more so than perhaps other people. Maybe they are a little more prone to getting exertional muscle cramping, things along those lines. Then doing the testing, screening for sickle cell trait is actually not terribly complicated, not usually terribly expensive. So I think the individuals who again, seem to be having issues, whether it's lots of muscle cramping, lots of exertional rhabdomyolysis, or just kind of generally are struggling a little bit more, and you're wondering, is this going on? Generally a pretty simple laboratory test just to screen for and potentially confirm the presence or absence of that hemoglobin S gene.
Cool, thank you. Right, we've got questions coming thick and fast now, which is good. There's a really nice contextual one from Josh in the chat. So we'll go for that, and then I'll try and filter through some of the others. So Josh works as a physical therapist, a physiotherapist within a hospital setting, and occasionally has very active patients who develop PEs post-joint replacement. Generally, what would be your advice protocol with return to sport for those people?
Yeah, I think so. I mean, it is of course going to be case by case. I know that sounds like a cop out, but it's just the truth. But that said, yes, I mean, you're definitely going to follow all guidelines in terms of appropriate anticoagulation. So at least 3 months, determination of whether it's felt to be provoked. Again, in the post-op setting, you would expect it's likely going to be considered a provoked PE. And then I think, depending on the severity of the PE, right? Like how much lung tissue was really damaged, your rate limiting step may actually be cardiopulmonary reserve. But for individuals who didn't have much of a cardiopulmonary hit, again, probably going to lay low for the first 3 weeks or so, allow any residual clot that might be in a vein somewhere to endothelialize, kind of like that, really scar into the vessel wall so it can't break off and send another PE. You're going to be on the medication to stabilize that. But I mean, I think a pretty gradual symptom-guided return to activity is fully appropriate. I personally would not have concern about a little bit of return to sub-maximal weightlifting and resistance training, starting after 3 weeks on anticoagulant, a little bit of return to running at that point, and then progressing kind of week by week from there. So I think in some ways it comes down to what's the goal, what's the objective, what's the timeline for that. But I think it is I'm generally not that different than any other progression back to activity after surgery, right? It's going to take some time. You have to ramp up. Don't skip steps, but as they clear each hurdle, you can certainly progress as you normally would, bringing someone back from illness or injury.
Right. I'm going to squeeze one more in. because it's a really good question from Adrian in the Q&A. So are all the therapies that we've discussed for iron deficiency, anemia, etc., compliant with the WADA prohibited list?
Yeah, it's a great question. So everything like blood thinners, anticoagulants, definitely yes. For iron deficiency anemia, you do have to be a little bit careful. I think IV iron can potentially get you in trouble. I think the timing is part of that, and it depends a little bit on like not necessarily just WADA, but different like individual sports. Like sometimes have different rules. To be honest, I actually haven't referenced IV iron with WADA anytime recently, so I'm going to give a non-answer so I don't give you the wrong answer. I don't know for sure. Again, should be relatively easy to reference, but that would be the one that would give me the most concern that I would definitely want to check. But I can't think of anything else I've discussed that might be an issue. Certainly oral iron supplementation is not an issue, and obviously dietary changes would not be an issue. I can't think of anything else I've discussed tonight that would raise concern with regards to WADA.
Excellent. We'll wrap up. Andrew, can I bring you back in as well if you've not run away? You're getting a lot of love in the chat. I can see that, Josh. There's a lot of compliments for your presentation in there, and I know why. It was a really, really good, informative session. Andrew, any comments from you before we wrap up?
Just say thanks very much. Like you said, a lot of evidence and science in there, but I think you helped to make it understandable to sort of practitioners, regardless of which sort of role they're operating in. And it's really interesting to pick up on some of these problems and diseases that people maybe haven't heard about or studied in any great detail before. So thanks everyone for joining. Yeah, thanks very much, Josh, for kindly sharing all your expertise. And then hopefully, if you're back in the UK with the NBA, we'll see you in this country at some point.
Yeah. Thanks very much. I appreciate the invitation.
Thanks very much, everyone, and thank you again, Josh.
Of course.
All right. Bye-bye.
Bye-bye.